Hello, my name is Benedict. Today I'm going to talk about the factors that influence maternal and reproductive health. The health of the mother during pregnancy and childbirth was not the focus for policy making, research and programming until 1985 when a seminal paper provocatively entitled Maternal Health, a Neglected Tragedy, Where is the M in MCH, Maternal and Child Health, was published. The paper called on multilateral agencies, particularly the World Bank, to prioritize maternity care, considerably reduce maternal ill health and deaths, and encourage contraceptive practice. In 1988, the World Health Organization made a film called Why Mrs. X Died. The film sought to raise awareness on the millions of women and babies who die each year from pregnancy and childbirth. Since then, mountains of evidence of women dying from preventable causes during pregnancy and childbirth have been generated, and also significant improvements in maternal and reproductive health. But we still have a long way to go. Despite all our knowledge, women and children still die every day. Why is this? Why has it been so hard to improve maternal health? Why are so many women denied the right care or medicine? Why are contraceptives still not available to all that need it? Why do these women keep dying? To be able to answer all these questions, we need to identify the factors that influence maternal and reproductive health. I would like to revisit the story of Mrs. X in a modified version. Let's call it Why Miss X Died Revisited. Miss X started her pregnancy already exhausted. She had not chosen to be pregnant, but it had happened because in her community, unprotected sexual intercourse was the norm, and healthcare services didn't offer contraception to girls of her age. Family planning services were available, but only to older women who were mostly married. Miss X's best friend had died 5 years earlier from an unsafe abortion. Even if her friend had wanted to keep the baby, she couldn't, because in their society, being young and single and becoming pregnant was highly stigmatized. And in their country, abortion was illegal. Since Miss X's friend had died from an unsafe abortion, she felt that she had no choice but to keep the baby. She had no support from her male partner who blamed her for becoming pregnant. But in one way, Miss X had been luckier than many others in her community. At least she had had a childhood. Many girls are married off whilst they are still children, not physically or mentally prepared for childbirth or motherhood. Because of poverty, lack of knowledge and tradition, giving birth at home was still the norm in Miss X's community, and the nearest healthcare professionals were far away, and the only way for Miss X to get there was to walk several hours on foot. She didn't know the importance of antenatal care, and many people around her told her stories of how they had been treated harshly and disrespectfully by hospital staff. There were even stories of people who had had to pay bribes to get the care they needed. All of this made her wary of seeking the help that she needed, and she had also planned to give birth at home, like so many others in her community. What she didn't know was that she had an anemia. During childbirth, she developed a life-threatening complication. She started to bleed. If Miss X had had the right transport, she might have made it to the hospital with facilities for comprehensive emergency obstetric care. Her life and that of her baby might have been saved. Miss X didn't make it to the hospital in time, and both her and her baby died. Through their pregnancies, Miss X and her friend faced barriers that prevented them from receiving the care that they needed. Each of these barriers can be removed, yet many or all of these barriers still exist for millions of women today. Miss X and her friend didn't die only of a hemorrhage or abortion. They died from social injustice, poor healthcare services, negative social norms, poor policies, and lack of political will. As we have noted from Miss X and her friends' cases, many interacting factors play a role in the way women and girls use maternal health services and the maternal health outcomes. I'm going to talk about 4 groups of factors: health service factors, political factors, societal factors, and individual factors. In most low-income countries, coverage of essential maternal health interventions such as family planning services, antenatal care, availability of skilled health professionals, immediate postnatal care, and basic and emergency obstetric care and neonatal care is low. And even in places where these services are available in limited numbers, they may not be accessible at a low cost for women and girls who need them the most. Some of the challenges with maternal health services are inadequate staffing, inadequate services, lack of information, poor financing, poor infrastructure, inability to pay for services, and lack of medical devices, among others. Governance of maternal and reproductive health is another key factor that influences use of maternal and reproductive health services and related outcomes. Improvement in maternal and reproductive health demand political will, effective women-centered policies, and accountability. The International Conference on Population and Development, ICPD, in 1994 began a paradigm shift from earlier policies targeting population control to one that places the individual at the center and respects choice, rights, and empowerment. Sociocultural vulnerabilities also play a role in preventing women's use of maternal and reproductive health services. For example, some women like Ms. X place a high value on home births and fear they will lose social status, confidentiality, and control over the birth process with assisted delivery. In some instances, the decision to deliver at a facility is not up to the woman, but is made by husbands, mother-in-laws, community heads, soothsayers, or traditional healers. Many women prefer and seek to give birth under conditions where they feel safe, protected, and secure. In some societies, a woman may seek antenatal care only once during her pregnancy, just to obtain an antenatal card, but less concerned about monitoring how the pregnancy is progressing. For such a woman, giving birth at home is her first priority, and she would only seek professional care after several failed attempts to deliver at home. In other instances, when women get to know that they carry a high-risk pregnancy during the first antenatal care, they will continue to attend more antenatal visits only to confirm that the pregnancy is progressing well. And once assured, they may not seek skilled care at the time of delivery. Other societal factors that prevent women, especially single, young, and unmarried women, from seeking or receiving family planning services or safe abortion are stigmatization, lack of acceptance, prejudice, lack of confidentiality, and unwarranted criticism. Therefore, most of these women and girls avoid seeking such services, and instead, some seek the services of informal or traditional healthcare providers who are perceived to offer greater confidentiality and privacy. Some individual level factors also influence women's use of maternal and reproductive health services. These factors include women's age, level of education, level of income, type of occupation, marital status, and place of residence. There is interplay between the individual level factors and all the other factors that either promotes or discourages the use of maternal and reproductive health services. Lastly, I want to talk briefly about the 3 delays model. The 3 delays model is divided into 3 phases. Phase 1 is delay in decision to seek care. This is influenced by low status of women, poor understanding of complications and risk factors in pregnancy, previous poor experiences of healthcare and financial implications. Phase 2 is delay in reaching care. This is influenced by distance to health facilities, availability and cost of transport, poor roads and geography. Phase 3 is delay in receiving adequate care, which is influenced by poor facilities, lack of medical supplies, inadequately trained and poorly motivated staff, and inadequate referral systems. So as we can see, maternal and reproductive health is influenced by general as well as contextual factors. These factors need to be considered in interventions aimed at improving maternal health. Addressing these factors that I have talked about will help to reduce the 3 delays and improve timely access to maternal health care.